A small caveat right up front, and that is that the common thread of interest I have, I started out with peripheral nerve problems, neurophysiology, EMG, and we did a lot of fundamental stuff for that as a field. And then I've always liked research, and I found out that there was very little research support for peripheral nerve EMG and peripheral nerve problems. So I was asked by a guy you may all know, Buster Alvord. He's pretty well known in Seattle. He was a nerve pathologist at UW. And he asked me to start the MS clinic back in the 70s, which I did, and I had been involved with that until I kind of went to emeritus, and I'm still doing research in MS. So the work I'm going to show you is you might think it's old, but it's still new because it's not really out there. And I'm going to try to make a case that physiology has a role in looking at nerve pathology in the spine, similarly to the median nerve conduction studies, which hopefully all of you would order before you do a carpal tunnel decompression. That the physiology of a problem like this can be teased apart and can be very helpful in knowing how to manage it. So I'm going to have 2 take-home points for residents. Physiology is better than imaging in detecting neural damage in suspected lumbosacral stenosis, neurogenic stenosis. That physiology has a big role. And if it's abnormal, patients need surgery because our follow-up clinical data would indicate that if there is considerable physiologic deficit in these patients with spinal stenosis, conservative management really doesn't work, and it's kind of a waste of time. So those 2 points. First is that there is a role for physiology, and if physiology is abnormal, surgery is really the only effective treatment. What I'm going to present to you is something strange because we developed the technique of doing dermatomal SEPs, and I'll show you with some pictures what that exactly is. There is a role for this which we developed through Dr. Jefferson Slimp at the UW starting in the early 90s. And we were very active in the 90s and early parts of this century in doing this. And so this, because a number of surgeons, including Dr. Chapman, were part of what we were looking at, and some of his predecessors in orthopedic surgery at the UW, because we were doing this, they were using this to help determine whether surgery should be done or not. So we've published a number of papers on this, but we never had a prospective blinded study. And so Michael Amanoff, who you may or may not know, for 10 years, he's a neurologist down at UC San Francisco and a good friend of mine. He was the editor of Muscle and Nerve, a journal of Muscle and Nerve, which is the physiology journal, physiology and medicine journal. And he said, you need a blinded study, a prospective study. But it was impossible to do because we had already biased how some of the surgeons were looking at management of this disease. So our solution was to do something unique, which one might criticize, but I want to tell you what I call it, a retrospective. It's a blinded retrospective prospective study. And so I'm going to talk a little bit about that too. And remember the 2 take-home points. Physiology is better in determining whether a patient has neural disease in the spine, and if it's there, surgery is really better than conservative management. So this is clearly the prototype of the patient with lumbosacral spinal stenosis. And that patient takes a forward flex position because I'm going to make a tube out of the map of this campus. So this is a tube. And the space in that tube is greatest if it's straight. So with the lumbar lordosis, there is a reduction in size of that central space, which is why patients with stenosis want to lean forward, and they don't really use the cane so much for support as a stroke patient would. They use it to allow them to move their center of gravity a little bit forward. And you hear the classic story of the patient who goes to the grocery, leans on the grocery cart, goes forward. As one goes in the grocery, you see some of these people still. So the classic posture of the patient with lumbosacral spinal stenosis, neurogenic type, will take this position. And all of you know, I don't need to dwell on this, but you know that the problem is with aging, which is what lumbosacral spinal stenosis really is, it's kind of a disease of older people. With aging, there is a narrowing of the disc and osteophytic development, and ultimately there is encroachment on the spinal canal. So, and you all know that some patients have a small, relatively small canal, and some have a relatively larger canal. With patients with larger canals with more space. But you take what the patient's got, and you have to deal with that. So our concern, our area of interest is really this area here. It's the area distal to the caudate equina. And spinal stenosis we're talking about is usually a disease of someplace in this lower lumbar or upper sacral area. It is because it's really analogous to the fact that with carpal tunnel syndrome, there the tunnel is compromised for various reasons, and physiology will really detect that more exactly, just like the dermatomal studies are going to, I think, detect the lumbosacral spinal stenosis a little more exactly than the imaging. You're all familiar with this. But there's a long, I miss my pointer, there's a long area here of concern. And as I said, if there is a patient who has a relatively smaller canal and they develop osteophytes and compression and bone overgrowth and so forth, they're going to compromise that further. Now, one thing that is not fully appreciated is that in the human body, the root itself is produced, really comes together from rootlets, but the root is formed really basically at the foramen. So all this stuff we're seeing in here are really rootlets kind of stuck together. And the interesting thing is that if you take each one of these and look at them, the afferent fibers, the sensory fibers, are in the periphery, and the motor fibers are more in the central part. And teleologically, I told my residents that this makes sense because it was probably better for our ancestors to be able to have good motor function and run away from the saber-toothed tiger than to feel the pain of running on the rocks away from the saber-toothed tiger. So the body protects motor function. So that's what makes lumbosacral spinal stenosis neurogenic type so difficult, because the symptoms tend to be sensory or pain. They don't tend to be motor. And if you send a patient for an EMG, regular needle EMG, it's going to be probably negative. An EMG is good if you've got a single root problem as at the foramen because it catches the motor roots. An EMG is really a study of motor function. What we've got here is a sensory disorder. So you've got this patient who wants to lean forward to open up that space. You've got them who have pain, and the pain is very hard to separate simply from that pain that you get if you have lots of degenerative changes in the spine. How do you make the distinctions? How do you figure this out? Hence our study. So our retrospective, prospective study worked like this. We pulled charts. I'm getting ahead of myself here. We pulled charts from 2 years in the 1990s, late 1990s, of all patients who had dermatomal SEP studies, who were referred to the departments doing neurophysiology at either Harborview or University Hospital for 2 years, who had orders for neurogenic studies, dermatomal SEPs, with suspected clinical lumbosacral spinal stenosis. And We pulled these charts. They were given to blind investigators who pulled out the physiology data and the imaging data. And the physiology data were sent to blinded physicians to interpret the curves, the traces, and the imaging data was sent to blinded radiologists to look at scoring of the degenerative changes. So we were comparing the degenerative changes with the physiologic changes. But before I get into all those issues, I'm going to comment that our techniques of looking physiologically is a little different and a little tricky, and it's difficult. We would want to really study the afferent fibers, because that's what SEPs are. They are the study of either afferent fibers in mixed nerves or separate sensory fibers in dermatomal studies. Jeff Slimp, whose name came up before, spent many, many years in surgery looking at patients who had various surgical lesions and has put together a map of really what are the best spots to stimulate to do a sensory dermatomal physiologic study. S1, lateral part of the foot, L5 here, so forth. And the recordings were made at the scalp. We're looking at the contralateral somatosensory cortex. So we're stimulating the periphery based upon the patient's symptoms, and we're recording the impulse over the contralateral, well, actually over bilateral somatosensory cortices. Here is, for example, the way the stimulus would be given. And the important point here, and this is a tricky point, is that this is an extremely difficult technique, because if you would stimulate, for example, on the right side, let's say the S1 dermatome down on the foot, and record, you would think you would record over the contralateral cortex. But remembering the homunculus, the foot, which is where we're stimulating, is really embedded in the central sulcus in the cortex. So it's down in. And so when we measure this, we actually put electrodes on really the central part of the head, because that's the best way to record from something below that point if you're going to measure the latency. And these latencies run like 30 to 40 milliseconds. So it takes that long to get an impulse from the foot up to the brain. But this is technically very difficult because not all people are made the same. And looking at this, you would think that, this is simple because that's where the foot is. It's in this central sulcus. No, it may be out someplace else. So to get past that, and this is something that other labs who have tried to do this have had problems with. They've not gotten past this point. To get past this is something to look at for a moment. So if we take, let's say, the right. So let's say we're stimulating the right S1 dermatomal area on the lateral part of the foot on the right. You would think you would want to pick it up either centrally or on the left. Well, this is a study that was done looking at large groups of patients, finding that, as I said, not all people were built the same. 92%, only 76% had a response at the central part, the CZ, the middle one. 20%, it was off to one side, on the opposite side. But it was, this was on the same side, 20% on the same side. And you can see that these are not as clean as you would like. So different people have their cortex kind of infolded in a little bit different ways. So what we did is we did recordings over the midpoint of the cortex of the brain, somatosensory cortex, and then a little bit lateral to the right and a little bit lateral to the left. And we took the best of the three traces. Other people have not done that, and they've tried these techniques. They don't know why they don't get good results. But you simply have to sample at least 3 spots in both sides of the somatosensory cortex. And the setup is to get the patient relaxed and stimulate peripherally and record centrally. Now, each of these recordings would be a minimum of maybe 200 or 300 quick little sensory shocks, which were 3 times the sensory threshold. It's very tolerable. I myself had a problem with a disc, and I went through this myself to look at this, see what it was like. And honestly, it's very easy to fall asleep during this study because it's just a minimal tingle, and it goes on, beep, 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 and you have to do a lot of stimuli at the periphery to get a response to the cortex. And then the electronics averages out the signal, and we pick the best one. These are examples of normal responses. This is 40 milliseconds here, and about 48 to 50 here. And you can see the dotted line is one side and the solid line is the other. But we get these nice, clean responses if we pick the right side of the brain. And these are normal responses. These are normal responses in healthy volunteers. As you would expect, as you move up, as you go from S1 to T10, it's going to get shorter because the distance is shorter, right? So they're not totally symmetrical. There's a little bit of variability, but they are nice, clean responses that you can usually identify quite nicely. Pathology is identified as either having a prolongation of one or more of these traces, because with nerve compression causing demyelination, there can be conduction block or conduction slowing across that segment. So pathology was identified as either absent response, if it's really bad, or prolonged response. Here are some traces from patients with pathology, and you can see the absence. I mean, this is a clear-cut picture showing the absence of responses on both right and left side, and on here on the right side, absence at L4. L4 is okay on the left side, and this is the kind of picture you get with patients who have neurogenic lumbosacral stenosis. And another patient, much more severe patient. Typical findings of patients with this neurogenic stenosis. So, our background is that the neurogenic lumbosacral spinal stenosis really gives a varying picture, but I did outline the clinical pattern and the physiologic pattern. And you know the radiologic pattern. I didn't need to show you that, but that there is a reduction in size of the space for the rootlets in the cauda equina. So which is better in a prospective way? So what we did is we pulled this information over 2 years. Between 1996 and 1997, 24 months. And all the patients who were sent, who had suspected lumbosacral stenosis, were sent for testing in either Harborview or University Hospital. Those are the patients who entered into the study. And then we also needed there to be a follow-up period in the university system, so we could look at the clinical changes, whether they had surgery or not, and how useful this was as a diagnostic technique. I mentioned this. So we had to quantify this in some way. So the way we quantified it, we identified, on all of the imaging data that we looked at in these patients, all of them had some degenerative changes, because that's just what happens in this age group. There was nobody that had a completely clean spine. So on the imaging data, we quantified it based on level and the amount of stenosis, either minimally abnormal stenosis at 1 or 2 levels, or very abnormal stenosis at 3 or more levels. So those were our markers. And I mentioned how these were scored. The endpoint went to October of 1999 as far as clinical follow-up. Some of these patients were followed up a long time. And the DSEP technique was, as I mentioned to you. And again, we had 2 markers, 2 points to measure to try to quantify the DSEP technique. These were our criteria, and we based it called either normal, in which there was no indication of physiologic stenosis, which meant there could be one sensory root that was abnormal, but that could be accounted for with a radiculopathy, so that didn't count. So really the criteria physiologically you see is this multiple level involvement that I showed you in these traces. And we would consider them abnormal if it was absent response or prolonged latency, or reduced amplitude, or a symmetric side-to-side asymmetry. So these were quantified radiologically and quantified physiologically. I'm sort of rushing with a lot of data here. We used descriptive statistics, chi-square, odds ratios. Ultimately, we had 78 subjects who met the criteria that had this long-term follow-up. 26 were treated with surgery. That's about 1/3. And 52, 2/3, had non-surgical management. The determination of whether they went to surgery or not was really the gold standard. How do you define, if you're looking at something like this, how do you define what's your gold standard? So it's got to be what happened to the patient. And ultimately, patients who were treated conservatively but could not be managed and went to surgery defined those patients who needed surgery. And what we did is we found that in that group, the mean follow-up time was over 13 months, but some of them went a long time. The imaging results varied widely. As I mentioned, there was nobody that had a completely normal image in the lower spine. Subjects with abnormal DSEPs were more likely to have to require surgery and had surgery than based upon just the imaging value with normal SEPs. And this was statistically significant. And the clinical outcomes of those who had the surgery were better than those who were managed conservatively. Hence the take-home points that DSEPs, like nerve conductions of the median nerve in carpal tunnel syndrome, are extremely helpful in determining which of these patients with this syndrome need surgery. And the other point was, if they have these problems, really you cannot manage it except by decompressing, which is surgical. So our conclusion was imaging was not statistically significantly related to patients who ultimately had to have surgery, whereas abnormal DSEPs increased the likelihood of surgery. And surgery was correlated with better outcomes. We believe a physiologic tool such as this can be extremely helpful to surgeons in deciding what to do in managing patients with this syndrome. And it's very analogous to that in carpal tunnel syndrome. Thank you. And I hope I finished in time for a few questions.